Yes, good afternoon, everyone. It's Ken Murphy from GP Connections. We'll get it going. We still have some other people that are joining us as we go, but to be fair to everyone, we'll get started on time and the others can catch up. Just a reminder to everyone, down the bottom left-hand screen is a white box where you can click in and type some questions for Dougal at any stage, so that Dougal can answer the questions, and we'll keep the ball going. I'll hand it over now to Dougal to get it going. Thanks, Dougal.
Thanks, Ken. I'd encourage everyone to get their questions going live stream, for want of a better word, because this talk is not overly long. The topic is reasonably concise, so we'll whip through it and see what questions we've got. Otherwise, we'll have an early lunch break. So, afternoon, everyone. The talk today is about follow-up with skin cancer. I will divert briefly into related topics. And I should say before we start that I've got no set template for this. I'm a reasonably malleable person when it comes to follow-up with skin cancer, and it's based on the usual considerations of previous and future risk and family history and geographical location, and obviously whenever cancer is involved, patient anxiety. I've made most of my models on this loosely based around both the Australian guidelines and British guidelines. I did a few years of my training in Britain and a few years in Australia, so I've had a bit of both systems, and I really think that neither is perfect, and I've got somewhat of a hybrid model, and I'm sure you'll see that as we flick up the local guidelines with what I'm suggesting here, but we'll get going. Okay. So I guess this would sum up what how I basically think about all skin cancer. For what I consider low-risk skin cancers, and we'll get on to what they are, I generally see the patient back within a year, and then depending on how that patient feels about future follow-up and where they live, either each year or as needed. And I'm falling more and more into the as needed box, particularly for people located outside of Toowoomba. For high-risk skin cancers, well, even if the patient really lives a good distance away, it's worthwhile in the short period having someone look at them every couple of months for the first 2 or 3 years, and we'll talk about the different considerations and different cancers for that risk group. And I think that if I was to have any criticism of some of my dermatology colleagues around the country, is that they tend to, in small groups, follow up low-risk patients to infinity. And they tend to see low-risk BCC patients, one-off BCCs every 3 to 6 months for the next 10 years, and you do need to wonder whether those 20 follow-up visits would be better spent on 20 new patients as far as detection of new skin cancer and the greater good of the community. So I think we do need to balance the risk for individual patients with the incidence of skin cancer amongst the community, and on the downs, that's extremely high, whilst keeping in mind that patients are obviously anxious about the word cancer and a need to reassure them based on the current medical evidence and statistics. So, a lot of regimes have been suggested for follow-up of skin cancer. Most of them center around melanoma. Few of them are evidence-based. So most of the guidelines with regard to this, 3 or 4 dermatologists and a melanoma surgeon sitting around a table one afternoon every 5 years talking about what the best way to follow up people are. And so we need to keep that in mind and not follow them blindly. So we'll talk about the 3 common ones that we'll see in day-to-day practice: BCCs, keratinocytic dysplasia, either IECs and SCCs, or melanomas. I think if you've got any of these coming across your desk in the other group, Merkel cells and appendigeal cancers and other rare ones, soft tissue cancers, they should probably be referred on to the appropriate secondary care because they're a little bit tricky, and certainly management and guidelines for them change regularly based on new research. So as I said, these low-risk BCCs are extremely common in Australia, and this is the Australia-wide incidence. Clearly on the Downs, it's much higher than this, and even Western Queensland with your Celtic skin and male farmers, probably higher still. I really do think of BCC as two different types: your nodular or superficial BCC of the trunk and limbs, and your high-risk BCC. And they can either be BCC of the T-zone, so periocular nose, perioral, BCC of the ears, dangerous microarchitecture, so either infiltrative as a primary architecture or infiltrative as a recurrent BCC or in chronic scars and burns. We're recognising basal-squamous cancers more and more readily and recognising their aggressive potential both for local recurrence and metastatic potential. I'd probably view these now as equivalent to a moderately differentiated SCC. So even though they may say on the report basal squamous cancer, BCC with squamous differentiation, I think you need to take care of these and really be quite conservative in your follow-up and management. And even though your low-risk BCCs have got low chance of causing any trouble in recurrence, if you've got someone getting 2 or 3 in one visit, their risk over the next 2 years is probably 40%. So I think they would be worthwhile seeing, every once or twice a year over the next 2 years, just to ensure that you can pick them up early before they turn into a high-risk BCC or develop a BCC at a high-risk site. Okay, so this is an example of an aggressive BCC that can really cause trouble, and you get these around the eyes and the nose. You can need enucleation of the eyeball and taking out of nasal bone, etc. This is a BCC arising in a scar. We performed Mohs surgery on this 2 weeks ago. The scar was 20 years old, and you can see the central component is indurated and really looks quite bland and a little bit knobbly around the edge. Now I've only got the first Mohs cut on this, which is that's the first section we took from Mohs. That's down to antihelix cartilage and all around the perimeter of the lesion that you could see. And now that was positive throughout the deep margin and the entire perimeter. So you can see how aggressive these can be. We took us another 3 cuts deep and to a certain extent laterally to clear that. And so these infiltrative BCCs in scars and radiotherapy sites, you do need to show a lot of respect for, because they can get away from you. These ones around the ears can go down the ear canal or down onto the mastoid bone and require some pretty major surgery unless you get it right the first time. So what do? For the low risk ones, I see them generally within about a year, usually 9 to 12 months, just to check the scar, make sure there's no local recurrence, that they're happy with the scar. We do a full skin check because probably 5 to 10% will have a second lesion there. And then after that, I put it to the patient, well, if they wish to remain hypervigilant about follow-up, I'm happy to see them each year. If they're a long way away, I generally see them on an as-needed basis thereafter. For the high-risk ones, based a little bit on the patient and the lesion, I'll see every 3 to 6 months for 2 years, and then if all doing well after 2 years, annual after that. What do I do with topical therapy? Well, I think the big thing to remember when you use Aldara or PDT or FUX for IUCs is that you'll have a lot of post-inflammatory erythema lasting a month or 2 after you finish treatment. And so having people back within 2 to 4 weeks to analyse the site and assess efficacy or otherwise is really not very helpful at that stage. You need to let them settle down. So I usually give them 3 or 4 months, get them back then. This is not a dermoscopy lecture, but dermoscopy can be very, very helpful in differentiating any mild post-inflammatory erythema there from any residual superficial BCC. And I think without dermoscopy, it can be really difficult to tell. The vessels of a superficial BCC will usually be brighter and more sharply in focus, whereas your post-inflammatory erythema will just be a background light erythema with some out-of-focus vessels. So after Aldara, see them in 3 or 4 months just to check, and then each year or as needed after that. What do I do for SCC? Well, the recent evidence for SCC is that Breslow thickness, like in melanoma, plays a big part in the risk of metastatic potential. So I pay a lot of attention to the Breslow thickness in deciding follow-up or otherwise. For those thin SCCs, particularly well-differentiated SCCs, less than 2 millimeters, most of the evidence would suggest they've got no metastatic potential, and as long as everything is excised with good margins and there's not a large burden of solar keratoses or other high-risk features, I'm quite relaxed with that category. As you get deeper, particularly over 4 to 6 millimeters, you start to run into much higher risk of metastatic spread. And your other high-risk features that give you that 15% chance of spread, and we all know these SCCs of the lip and ear, transplant patients on multiple immunosuppression, quickly growing poorly differentiated SCCs. As far as perineural involvement, I usually am happy for small nerves to be involved as long as it's within the main body of the SCC and it's been fully excised with a wide margin. If I'm seeing SCC involving nerves outside of the body of the skin cancer, if there are close margins, or if the nerve is bigger than probably 0.07 to 0.08, I'll give the pathologist a call at that stage so we can discuss to what extent the nerve is involved and how worried they are about recurrent or metastatic disease, and either proceed to wide local excision and or radiotherapy at that point. Obviously, if you've got SCC involving nerves over named nerves, any of the sensory nerves of the face, you need to be a lot more careful as well, because they can follow those nerves through the skull into the brain. So with SCCs, as per the BCCs, I think there are two distinct groups here. You've got your quickly growing high risk, poorly diff SCCs of lips and ears, and you've got your elderly farmer with 50 to 100 sunspots on their hands and forearms and face, and they get 2 or 3 very, very slow growing, well differentiated small SCCs at the hands and arms, and I think they're extremely low risk, and we need to differentiate SCCs based on that risk profile. So what I do, much the same as the BCCs, the low risk ones, I see them back within a year for a check of the scar and another check all over. For the high risk ones, or in the patient with a huge burden of disease and popping up multiple low risk at a time, you probably see them every few months for the first 3 years before reassessing. If you've got someone that's getting 3 or more a year with a big background of solar damage and solar keratoses, I do think it's worth considering active treatment to decrease their future risk, and you can do that with either field treatment with Efidex, Aldara, PDT, or referring them on for consideration of an oral retinoid. And acitretin in these patients works extremely well at very low doses, so a lot of the renal transplant and double heart lung transplant patients we put on acitretin at doses of around 10 milligrams a day. It's probably a third to a fifth of the dose that bad psoriasis needs, and the mucocutaneous side effects are minimal, if any. The only consideration is that these patients typically are elderly, they're often on statins, and oral retinoids will increase your risk of myositis on statins, as well as individually increasing the triglycerides and cholesterol. So it will do that in about a fifth of the triglycerides and cholesterol, and the myositis risk probably increases it by 2 or 3-fold. So they're the considerations. Otherwise, it's very, very safe and extremely effective, and worthwhile in the patient that's popping up a number. And patients are amazed at a low dose and how much it turns these things off and stops them from growing. So IEC is obviously a local IEC on a non-hair-bearing site is extremely low risk without any potential to spread. What I would encourage you to do with IECs is to check the histology to check if it's ducking down hair follicles, because IEC that travels down hair follicles will form a reservoir of atypical cells, and the risk of recurrence after non-surgical treatment goes from 20% to probably 40 or 50%. For that reason, we'd suggest that you don't use non-surgical therapy for these at all, and it's always a surgical procedure that's performed when hair follicles are involved. Of course, that's not always practical. This is a lady I saw in Clayfield a month ago, and she has a superficial BCC here circled, an IEC circled more inferior or more posteriorly, another IEC more anteriorly, and she declined my suggestion for surgery of these sites. She's a 30-year-old lawyer in town. She couldn't take the time off work. She didn't want the pain. She didn't want the potential cosmetic change and scarring hair loss. So considering that she definitely wouldn't have surgery, we did proceed to Aldara treatment of all three. And I'm watching her like a hawk, and she's finished the first stage of treatment, and I'll be seeing her every month really, and if for an extended period until we're very, very happy, and then probably every 3 or 4 months after that, because this is a high risk treatment using topical treatment on IECs in hair-bearing sites. So I'd encourage you not to do that in primary care. Melanoma, well, this has been the big change in the last 3 years, has been the prognosis and staging of melanoma and subsequently guidelines for follow-up. So really, if today's series of slides can highlight anything, is that there has been a big change in this, and the Australian guidelines are yet to follow suit. So the AGCC revised their staging a few years back based on the impact of mitoses on prognosis. The Brits and the Americans followed suit soon after to change their guidelines, and we've lagged behind, and we've not updated ours since. So our guidelines won't mention this. They're a little bit out of date, and the British guidelines and North American guidelines are probably worth keeping an eye on if you want to be looking at the medical evidence. I've included a link to the BAD, the British Association of Dermatology guidelines, at the bottom of the page. And they do, if you're looking after something dermatological, the BAD do extremely good handouts and guidelines on a whole range of things, where they'll have 3 to 5 pages of common sense follow-up and approach. And for melanoma, this is a really good one. And if you've got any questions or extra reading that you want to do, this is a site I would point you to. So the main change on the prognosis is that for these thin melanomas, less than 1 millimeter, if there are no mitoses per high power field on the histo, that's been grouped as stage 1A with an extremely good prognosis. So you can reassure these patients the risk of them having any trouble with a thin melanoma less than 1 millimeter is almost zero. Whereas a thin melanoma with even 1 mitosis per high power field significantly upgrades the lesion and has a significantly worse prognosis. Now, the data suggests that these stage 1A, so the thin melanomas without mitoses, well, certainly less than 4%, probably in the realms of 1 to 3% chance of recurrence, so extremely reassuring figures. Here's a study from a few years back where 430 patients with melanomas had no recurrences up to 15 years, whereas if you go to stage 1B, so this is less than 1 millimeter with mitoses, this should be stage 2A. Apologies for that, past the forward slash. You're looking at recurrences of up to 35% within the first 3 to 4 years. So you can see that mitoses in thin melanomas make a huge difference, and we need to be paying close attention to them. So what I do is based on that, and as I said, this is a hybrid of the British and Australian models. For these thin ones, I see 6 monthly for 2 years and then each year, and I'm more looking to pick up a new primary than worried about a metastasis of the previously diagnosed melanoma. The British guidelines for this would be to see twice in the first year, then discharge. So you can see that they're taking a much more relaxed stance based on the data on these, and I guess the reason that I don't do it that way is because the incidence is a little bit higher in Australia than England, not terribly, but a little bit higher, and melanoma still has significant stigma around it. Even with reassurance to the patient, people will still be extremely anxious, even if they have very low risk, and seeing them every year for a full skin check is probably not the worst idea. But for these stage 1B, so the melanoma less than 1 millimeter with mitoses, I think you need to watch these very closely. And the British guidelines would be 3 monthly for 3 years, and then twice a year to 5 years, and that's how I do it. So keep an eye out for mitoses in thin melanoma. This is a question that I get from primary care time to time, and certainly patients will be asking you, is a CT warranted with thick melanomas? What about blood tests and ultrasounds? Well, the only the only clinical situation where investigations are required are if you have a melanoma that's stage 3. Now that is a melanoma that has nodal or systemic metastases or a symptomatic area. In the absence of any of those features, investigations are not warranted, and there is no evidence that they make any difference or will pick up anything of use. So I would simply reassure patients, if you have any questions in that regard, feel free to give me a call. But really in primary care, you shouldn't be needing to order any investigations for melanoma, because any of these stage 3 patients will be going through to a melanoma surgeon or an oncologist who then stage the patient appropriately based on the scans. So shouldn't be needing to do any investigations in melanoma. Of course, the dialogue surrounding sentinel lymph node biopsy continues. The benefit of it or otherwise is yet to be proven. The MSLT2 trial is currently underway, and the results from that should give us a lot more information. The first trial was a little bit nebulous in the suggestions and had some criticism as such. Generally what I'll do with these people is that anyone stage 1B or above meets criteria. Now, just to remind you, stage 1B is a melanoma that's more than 1 millimetres in thickness, or a melanoma that is less than 1 millimetres with mitoses. So either of those will meet criteria for sentinel lymph node biopsy. And at that stage, I don't feel terribly strongly about it. I'll have a discussion with the patient as far as the pros and cons. I really do stress that it is a staging procedure. It has no current proven therapeutic value. Most of the time people would like to continue that discussion with someone who does the procedure, flick them down to Brisbane at that stage. I think the important thing to recognise, and some of the opponents to sentinel lymph node biopsy like to brush over this fact, is that most of the clinical trials on the new systemic medications for metastatic melanoma, so the BRAF inhibitors and the immunotherapy, require a sentinel lymph node biopsy status as entry criteria into the clinical trials. And whilst you may think that is unfair for the patients who haven't had one, it is what it is. And if you have a patient with a melanoma that's stage 1B or above and they have a 30% chance of recurrence and metastasis, and they don't have a sentinel lymph node biopsy, and they're BRAF positive and they would greatly benefit from BRAF inhibitors, then potentially they've been done a disservice, even if the sentinel lymph node biopsy had been negative, because they've missed out on their chance for that therapy, and they're probably back to the dark old ages of cisplatin and the other chemotherapy that's not really very effective and quite toxic. So we need to keep in mind, even though sentinel lymph node biopsy has no proven current therapeutic value, there are criteria for the drug trials which are based around it. So, Lentigo maligna, we see a lot of this on the Downs in Western Queensland. Clearly, excision of an in situ level 1 melanoma carries no risk of metastatic spread, but these are often in a field of high sun damage with so-called atypical melanocytes and unstable lentigo, etc., petering out at the margin. So we need to be careful in the years after, because there's a high risk of local recurrence. So I tend to see these every 6 months for the first couple of years and then yearly afterwards. And I'm very, very cautious with analysing the edges with dermoscopy, biopsy of any suspicious areas, and even mapping biopsies, because I'm sure we've all seen these lentigo malignas where you have essentially featureless skin that is positive for atypical melanocytes in lentigo maligna. So you have to be very careful with these as far as local recurrence. And I make the point here that follow-up of lentigo maligna of chronically sun-exposed skin is very different to follow-up of level 1 superficial spreading melanoma of more sun-protected skin. So a level 1 superficial spreading of the arm or the back, fully excised with appropriate margins, shouldn't cause any more trouble, shouldn't have a risk of local recurrence. They have a risk of a secondary lesion over the next 10 years, so it's worth seeing them every now and then, but it's a far different follow-up to following up the large lentigo maligna that's been excised from sun-exposed skin. This is a group of people that we're recognising more and more, and there are a lot of them on the Downs in Western Queensland because of the Celtic skin. Anyone with red hair and freckles and blue eyes has a potential to make melanoma that's pink in the early stages. So any of your melanoma patients that have this skin phenotype, the Celtic skin, you need to let them know that melanoma is not always the brown and black ugly lesion that you'll see on the TV commercials and on the walls of your surgery, but a persistent pink patch that has no other good explanation for it should be considered a melanoma in people with high-risk features. So this is the typical timeline of pigmented melanoma, and you have eccentric, irregular, darker pigmentation. It's clearly a melanoma. The patient comes in worried about it. But with pink melanomas in these type 1 skin patients, it will be a pink patch for a long period of time before it develops any pigmentation which suggests that it will have a melanocytic basis. So you do need to be very, very careful. And here's four across different spectrum of pink melanomas. Clearly this is not the same patient that I've followed over 2 years and let them grow up to a big thick nodular melanoma. These are 4 different pink melanomas at various stages, and this is in situ disease, more extended in situ disease with little early features that it may have a melanocytic basis, and it really, before it gets to a stage that you're worried about it being a dodgy mole, it's quite thick. So for type 1 patients with type 1 skin, we need to alert them that these pink patches can be a risk for melanoma, and they should have them checked and not just wait till they get the big brown patch. So this is as I stated earlier, there's no great template for this. There's no page you can print off and stick on your wall. Just follow blindly, patient by patient. So if you have any questions, please get in touch either. I'm happy to respond to text messages as soon as I get them, and emails that night as well. So any questions, give me a call, get in touch on the email. I'm happy to respond, and I'm happy to take questions now, obviously. And just in summary, low risk, see them within a year and then as needed or annually if they're living closely and wish to be vigilant. And these high risk features, either the stage 1B and above melanomas, the aggressive SCCs, or the really high risk BCCs, probably every 3 to 6 months for the first 2 to 3 years. And that's it, Ken.
Great, thanks very much, Dougal. Just a reminder to everyone, you can type a question in down the bottom left-hand corner of your screen. So if anyone has any questions, I think you've either answered all of their questions, Dougal, or stunned them to complete silence.
Probably more of the latter, I think.
It doesn't appear to be anything coming through. Obviously, if after the session, if anyone does think of something that they want to ask, by all means, either contact Dougal direct, or we can certainly pass on the questions through to Dougal for you. But if not, just like to say thanks very much, Dougal. It was very, very informative, and I think it's certainly something that, particularly on the Darling Downs, the incidence is there that we need to be very vigilant about. Much appreciated.
No problems. Thanks, Ken. Thanks, everyone.